Welcome to the symposium titled Recent PTSD Research, Genetics, Family Interactions and Impact of DSM-5. My name is Maria Kangas. I'm based at Macquarie University in Australia and I have no disclosures. Post-traumatic stress disorder, or PTSD, has served as a potentially heuristic framework to encapture cancer-related stress across various cancer populations since the publication of DSM-4 back in 1994. And this came about because for criterion A, the objective stressor criterion, life-threatening illness such as cancer for the first time qualified as a potential traumatic event that could induce post-traumatic stress disorder symptoms. In DSM-4, PTSD was defined by three core clusters of symptoms, including re-experiencing and intrusions, avoidance and dissociative symptoms, and hyperarousal and reactivity symptomatology. As a result of introducing potentially life-threatening medical conditions as an objective stressor that could give rise to PTSD, there was an exponential surge of psycho-oncology studies across the lifespan that tested the prevalence predictors of PTSD in cancer populations, as well as some treatment outcome studies tested the efficacy of psychosocial treatments in this population. In terms of prevalence rates for cancer-related PTSD, the DSM-4 body of literature showed a highly variable rate depending on the type of sample tested and the type of measures used, ranging anywhere from zero prevalence and up to 55%, so more than 50% of a sample meeting criteria for PTSD. As mentioned, there was also a parallel growing volume of studies that started to look at psychosocial treatments targeting post-traumatic stress symptoms and or full clinical criteria for PTSD as a primary or secondary outcome measure. In DSM-5, which was published almost a decade ago, the PTSD criteria underwent a number of changes which has direct implications for cancer-related PTSD as a heuristic framework. Firstly, PTSD was moved out of the anxiety disorders and placed in a new category of disorders referred to as trauma and stress-related disorders. And this now also includes adjustment disorders. In terms of criterion A, the objective criteria for PTSD, this also underwent changes for DSM-5. In particular, the manual states, a life-threatening illness or debilitating medical condition is not necessarily considered a traumatic event. And this has direct implications for cancer because simply incurring a diagnosis of cancer no longer would meet this criteria. However, the manual also stipulates that medical incidents that qualify as traumatic events involve sudden catastrophic events. So this second part of the statement is still open to interpretation. In terms of carers and family members of cancer survivors and or people undergoing treatment into the recovery phase from children through to adolescents and adults and spouses, individuals who witness the event, this needs to include unnatural death, and learning about threatening life events must be violent or accidental in line with the current criteria. So this new caveat does have implications because violent and accidental traumatic events does not really fit a medical condition. The DSM-5 PTSD criteria shifted from three core clusters to four core clusters of symptoms as a result of factorial evidence that emerged through the DSM-4 era of studies. The four core clusters comprise the re-experiencing symptomatology, which has remained the same. It now includes persistent avoidance symptoms as a standalone core cluster, and the new criterion D of negative alterations in cognitions and mood, as well as criterion E, which is the old criterion D, but now in E, which is reflecting the physiological hyperarousal and reactivity symptomatology, yet the duration and impaired functioning criteria have remained the same across the two editions of DSM 4 to 5. In terms of duration, an individual can meet criteria at least 1 month after the stressor onset. As mentioned, with this new category of trauma and stress-related disorders, adjustment disorders has now gone into this new category. And the manual stipulates that adjustment disorders are common accompaniments of medical illnesses and may be the major psychological response to a medical disorder. So this does have implications for cancer sufferers. In addition, it is a transient diagnosis because it's no longer valid after 6 months following the end of a stressor period. In terms of patients who cancer survivors who only go on to meet subthreshold or partial PTSD, the manual does stipulate that adjustment disorders needs to be considered as a potential better fit. However, this does remain an empirical question in the oncology field, including paediatric oncological samples. So to that end, I'm very excited to hear the empirical findings from our 3 key presenters for this symposium, which are going to present on PTSD DSM-5 findings in relation to samples covering adolescents and young adults, childhood cancer survivors, as well as caregivers. Thank you.